Welcome to Chest Pulse. I'm Dr. Doreen Addrizzo-Harris, professor of medicine at the NYU Grossman School of Medicine, and I'm the director of the NYU Langone Health Bronchiectasis and NTM Clinical and Translational Program. And joining me today to discuss initial treatment strategies for patients with bronchiectasis and pulmonary disease are two very special guests. Dr. Keren Bakal, a pulmonary attending who works in New Jersey at Summit Health. Hi, Keren.
Hi, Doreen. Thank you so much for having me.
And we also have nurse practitioner Amy Springer, who is senior nurse practitioner at the NYU Langone Health Bronchiectasis and NTM program. Hi, Amy. Glad to have you joining us today.
Hi, thank you so much for having me today.
So as this title states, we are going to talk about the initial treatment strategies for patients with bronchiectasis and NTM pulmonary disease. As most of you may know, airway clearance is a key part of the treatment strategies in patients diagnosed with bronchiectasis. We know that almost universally all patients with bronchiectasis have a cough, most of them a productive cough, and most of them have impaired airway clearance due to abnormalities with ciliary dysfunction. So I want to start with Dr. Bakal. How important is it, Keren, to start airway clearance in these patients? And what is your approach to starting therapy?
So, airway clearance is extremely important, but we need to realize that one therapy may not work for all patients, and you want to take an individualistic approach to each patient and also provide the patients with support and education on the different methods that you decide to use in your practice. So there are multiple different strategies for airway clearance. So I'm just going to review a couple of the strategies and what my approach is. One strategy is actually just making sure the patients exercise. Exercise improves muscle strength and tone. That can be helpful to airway clearance. Some patients even benefit from postural drainage. There are also other techniques, such as using oscillatory positive expiratory pressure devices, like using an aerobica or a cappella valve. These type of devices create resistance with exhalation, which allows mucus to be mobilized out of the airways. In my practice, if I have patients use these types of devices, I have them use them for 10 to 15 minutes twice a day. Some of the devices can be connected to a nebulizer. Hypertonic saline is very important as well. I tend to start patients at 7%. Sometimes patients do develop side effects, and if they do, you can lower to 3%. Some of the side effects that patients might have are bronchospasm, chest tightness, or throat. I usually have patients use, if we decide to use hypertonic saline, we have them nebulize with that 1 to 2 times a day and use their positive expiratory pressure device. Something simple like just huff coughing also could be useful to patients. Huff coughing is an alternative to deep coughing. That can assist in airway clearance. Patients basically take a breath that's slightly deeper than normal and use their abdominal muscles to make a series of 3 rapid exhalations with the airway open. They make a ha 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 sound and follow this with controlled diaphragmatic breathing. And then with a deep cough, they can try to get the mucus out of their airways. And finally, there's also chest percussive techniques that some patients may benefit from. So if a patient has help at home, if they have a caregiver or someone that can help them, that they can actually do manual chest PT. And then there's also vest devices that provide high frequency chest wall oscillation, which can help with airway clearance. So it's really important, to tailor the therapy depending on the patient. You want to give the patient education on airway clearance. You want to make sure they make it a routine. And this helps allow them to comply with treatment. And you may need to schedule multiple follow-up appointments to kind of review everything in detail. In my practice, we refer patients to a pulmonary rehab facility where they actually give them education on the methods, including the oscillatory devices and nebulizers and using the vest. And some practices have a respiratory therapist on site, or they may have supportive staff that can review these methods in detail at the office appointment. And finally, I just want to mention pulmonary rehab, which is extremely important for patients who can't exercise adequately on their own. Pulmonary rehab can be effective in improving quality of life, stamina, providing upper body weight training and breathing techniques, and showing patients how to do the huff coughing techniques.
Thank you, Karen. That was very comprehensive. And I really want to point out that there are many different therapies in deciding which therapy often can be difficult. I want to let the listeners know that we will also be offering a webinar on airway clearance so that you can visualize how some of these techniques should be done. I don't want anyone to feel like if they don't have a pulmonary rehab service or if they don't have a respiratory therapist in their practice that they can't start airway clearance for a patient. I would say that starting the positive expiratory pressure devices like an aerobica or a cappella along with hypertonic saline is something that is very easy to do initially. So you certainly can start that and then refer to perhaps a larger center that is in your region where they have a pulmonary rehab center or where they have access to respiratory technicians. So don't feel like you can't do it because you don't have all of the resources. And I also did want to point out that in those patients who can exercise, increasing a standardized exercise program sometimes is the easiest, cheapest, and most efficient way to improve airway clearance. But as we know, there are many obstacles with starting airway clearance, and then sometimes obstacles that patients have with staying on airway clearance. So I wanted to invite Dr. Springer now, NP Springer, to let us know what are some of the obstacles and challenges that she encounters in her practice, and how does she overcome them?
So there are obstacles that we encounter as providers when prescribing airway clearance. First is the availability of the hypertonic saline, as not all pharmacies carry it. We do typically like to start our patients at 7% hypertonic saline. However, this may be out of stock at certain pharmacies or even on back order. If 3% hypertonic saline or even 0.9% normal saline is available, we typically have to pivot and start at this lower percentage to at least have patients initiate airway clearance, as this is key. If we are unable to get any percentage of hypertonic saline, then we may recommend, as Dr. Addrizzo pointed out earlier, the importance of exercise and perhaps doing just exercise with a flutter valve and no saline, as again, the key is to start airway clearance. There are also obstacles in obtaining vest therapy for patients. Obtaining a vest, which is the high-frequency chest wall oscillation device, requires specific documentation in order for insurance companies to approve it. Patients need to have either a daily productive cough for more than 6 months or 3 or more exacerbations requiring antibiotics in the last 12 months. However, there are some patients who are asymptomatic but have progressive disease on their chest CT scans despite airway clearance. They are unable to mobilize secretion successfully with hypertonic saline and the aerobica device with or without exercise, but unfortunately, this does not qualify for vest approval, which can then make the patient not be able to obtain the vest for therapy. In addition to all of this, there's also a need for repeated instructions, as patients also need re-education and reinforcement and hands-on teaching, whether this is the physician, the nurse practitioner, a respiratory therapist, or at a pulmonary rehab center. Given busy patient clinic days, there may not be enough time to provide hands-on teaching at the time of the appointment. Given this, we utilize the option of video visits after the in-person visit to further discuss airway clearance and watch patients use their own devices at home to ensure accuracy and have the time available to answer any questions or concerns that they may have.
Wonderful. And what about additional patient resources that you might have uh, available to you to give patients for education? What do you use, Amy?
So there are resources online that provide educational videos that the patients can watch, as well as they can always reach out to a local patient support group, and maybe local patients can also help provide help if they need it.
Absolutely. So, in addition to face-to-face education or video visits with either our nurse practitioners or our respiratory therapists, organizations like the Bronchiectasis and NTM Association have materials that you can give the patient. The NTMIR group has patient materials as well on airway clearance. And again, you can even refer your patients to the webinar that is going to be created with this series. So they can watch the webinar, both providers and patients can watch the webinars on airway clearance. So I thank you for discussing airway clearance, because we know that for most patients, this is going to be a part of their treatment regimen. So getting this going first before a decision is made on further treatments is really, really crucial. In the next segment, we will talk about pharmacologic treatments, but I would like to, for those that are just tuning in, let them know that you're listening to Chest Pulse. And I'm Dr. Doreen Addrizzo-Harris, professor of medicine at NYU Grossman School of Medicine, director of our bronchiectasis and NTM program. And joining me today to discuss initial treatment strategies for patients with bronchiectasis and NTM are Dr. Keren Bakal, who is a pulmonary medicine attending in New Jersey at Summit Health, and senior nurse practitioner Amy Springer from NYU Langone. So thank you both as we go on to the second portion of our series. So when we talk about treatment of nontuberculous mycobacterial pulmonary disease, specifically first focusing on Mycobacterium avium complex disease, we need to think of several things. The first is we need to officially make a diagnosis of MAC pulmonary disease based on the current guidelines that were published in 2020. And so for that, you need to have microbiology that's abnormal. You need to have either two sputums that are growing the same species. Here we're talking about two sputums with MAC, or one bronchoscopy specimen, along with a radiology abnormality, most commonly chest CT scan showing bronchiolitis, or what we call tree and bud disease, or bronchiectasis, and then a patient having symptoms. If you have all of those three together, you can make a diagnosis of NTM pulmonary disease. Of note, in the newest guidelines that came out in 2020, once you do have a species identified, and in this case, Mycobacterium avium complex, it is recommended now that an initial antimicrobial sensitivity testing be performed on all initial specimens. So sending it to either your lab, if you're able to get sensitivity testing done, or sending it to one of the other national labs that do testing, that is quite important. The next decision that you're going to have to make is, do you treat the patient, or do you just monitor them, to treat or not to treat? And here I think it's extremely important to look at the history of your patient. So if you've had a number of CAT scans that were performed at an outside institution when you're first seeing the patient, looking at the progression of the disease is extremely important. There are many patients who will have a mild cough, but when you look at their CAT scans, they may be very stable over many, many years. In that patient, you may just want to start airway clearance therapy and do nothing else. And then there may be other patients who you can see declining pulmonary function testing, progression of bronchiectasis on CTs, maybe heavy culture positivity or smear positivity, and that would clue you into that being a patient that you would want to treat. There are a number of other risk factors that you should consider when deciding how progressive a patient's disease is going to be. We know that patients actually who are male do worse than females. We know that patients who are immunocompromised, whether if it's because they've got immunoglobulin deficiencies that you may find, or that they're on immunocompromising drugs, those patients will usually progress. We know that those with a heavier burden of disease, who are smear positive or who have cavitary disease, are more likely to progress. And then we also know based on that species, and we know that in comparison, Mycobacterium abscessus, for example, is much more aggressive than some of the slow growers like Mycobacterium avium complex, or Mycobacterium intracellulare, for example. You may have more time to wait when you're dealing with those, but when you're dealing with Mycobacterium abscessus, you may want to monitor your patient much more closely or start therapy much earlier, given that we know that those rapid growers will progress more quickly. So once you've decided that you have a patient who has enough disease and symptoms that you would like to control, so you want to start them on pharmacologic therapy, I'm going to ask Amy to tell us what do you do? What do you decide? How do you decide what treatment regimen to start them on, and how does their CAT scan play a role in that decision?
So first we have to look at whether the patients have either cavitary or nodular disease, as this differs in terms of how we do approach their treatment. And when we're treating patients with nodular disease, the guidelines recommend a macrolide, a ethambutol, and a rifamycin at 3 times a week dosing. Based on the guidelines, azithromycin is recommended over clarithromycin because of the side effect profile, as well as the ability to take once-a-day medication versus twice-a-day medication. Rifampin is typically recommended over rifabutin, also because of the side effect profile. In addition, if you are at a center that has availability of clofazimine, there have been several studies showing that clofazimine can be substituted for the rifamycin family and have positive patient outcomes. When we're looking at patients that have cavitary MAC lung disease, the guidelines recommend a macrolide, a rifamycin, and a ethambutol at daily dosing with the addition of IV amikacin. Standard dosing of IV amikacin is 3 times a week therapy, usually starting at 15 milligrams per kilogram, depending on patients' other comorbidities. When patients are on 3 times a week therapy for the IV amikacin, we typically obtain weekly labs. The weekly labs were also able to obtain peak levels to make sure the patient is being adequately dosed, as well as weekly amikacin trough levels to make sure the side effect profile is kept to a minimum. IV amikacin is typically recommended for about 2 to 3 months for the treatment of cavitary MAC lung disease. However, there are patients who may be on IV amikacin for longer. For example, there are patients who may be going for surgery, and we want to continue the IV amikacin for a period of time post-operatively, as well as patients with severe cavitary MAC lung disease, and they may have a minimal side effect profile, in which case we may decide to prolong their therapy of IV amikacin for longer than 3 months. There's another treatment option that one could consider for patients with MAC lung disease, which would be surgical options, particularly in patients with localized disease, and this would be done in conjunction with pharmacological therapy.
Wonderful. We'll get on to talking about the side effects in a second. But Amy, so you divided it based on the guidelines into nodular and cavitary treatment. But there are patients, as we know, that may have fairly extensive nodular disease, and perhaps they've also got an additional comorbidity, such as being immunocompromised for an inflammatory bowel disorder or rheumatologic disorder. So we leave that up to the clinician. That patient may actually benefit from more aggressive therapy up front. And in that case, you might use daily therapy instead of the 3 times a week. And you can always back down to 3 times a week therapy if you see a very good rapid response to treatment from a symptom profile or from a culture negativity profile. We know that patients who have MAC lung disease actually, at most centers, conversion is in the percentage of 75 to 80%. So macrolide sensitive mycobacterial avium complex disease is usually easily treated. And that is for patients with nodular disease. Once we have patients that are in the cavitary disease group, we see those numbers fall significantly. So that's something, to be aware of. That's why using surgical options in patients with cavitary disease really needs to be thought up front, because if you have localized disease, you may be able to cure those patients much more easily if surgery is part of their regimen. The other thing I wanted to point out is that starting IV amikacin can be done in a number of ways. And so, Amy, why don't you let us know what is your approach to getting a patient on IV amikacin as far as getting the intravenous access performed and then having the medications available to the patient?
Yeah, so typically what we have to do is first have the patient get a PICC line placed as an outpatient. In addition to that, we have to have home health care agency and nursing services set up. At this point, and they would then approve the medication and run it through their insurance company. Once everything's approved and the patient starts the medication, the home healthcare agency and nursing team will go out once weekly to the patient's home. At this time, they would do weekly dressing changes as well as the weekly set of labs that the provider may order. And then we are really in touch with the patient on a weekly basis, providing them with their results and trying to see if we need to adjust any of the dosing at that time.
Wonderful. So this is something you can do fairly easily in your own practice. If you need, there are obviously centers that you can refer these patients to. I'm going to turn to Dr. Bakal to talk about, you now have a patient who's on azithromycin, ethambutol, rifampin, and potentially intravenous amikacin. Lots of side effects can occur in this group. So I'm going to let Dr. Bakal talk to us a little bit about what the major ones are that we should be aware of and that we should educate our patients about.
Okay, thank you. So I'll start with just many of these medications can have gastrointestinal side effects, and patients can develop a rash with any of these treatments. With azithromycin, patients can develop tinnitus or hearing loss. For those patients who are starting on treatment, you want to get a baseline audiology exam and have a follow-up exam. You also want to monitor, azithromycin can also cause QTC prolongation, so you want to get a baseline EKG prior to starting treatment and monitor the EKG. Azithromycin can interact with a number of medications as well. So you want to see what other medications the patients are taking and make sure there's no interactions prior to starting that drug. With ethambutol, this drug can cause optic neuritis. So you want to get a baseline eye exam and refer to ophthalmology. They may need a follow-up exam as well on the ethambutol. And you also want to monitor for peripheral neuropathy, which can develop on this drug. With rifampin, liver function abnormalities can occur. So you want to get a baseline LFTs on the patient and monitor their LFTs while on the drug. Patients can also develop gastrointestinal side effects. So you want to just let the patients know about that and monitor for any GI side effects or intolerance. Patients should be aware that while on rifampin, their secretions will turn orange. So you want to let them know about that. That's just something that they're going to see and they can continue on the drug. with amikacin, you talked a little bit already about the monitoring that needs to be done with that. Amikacin can affect the renal function. You want to monitor patients' renal function while on the drug. Amikacin can also cause ototoxicity, so patients should have baseline audiology testing prior to starting treatment and have follow-up testing on the drug. If they develop ototoxicity, they will need to stop the medication. So as far as timing of monitoring, just some of this was already touched on, but for their LFTs, you get baseline labs, monitor their labs every 3 months. You can also monitor their CRPs while they're on treatment. And again, all these patients should have a baseline eye exam and audiogram and then have follow-up.
Thank you. And a lot of the follow-up is not prescriptive. It's very much individualized based on your patient and their comorbidities. So the older they are, if they already have some renal insufficiency, you may increase the follow-up period. You may increase the timing of your ophtho exams or your audiograms. We typically will see a patient 1 month after starting therapy and then every 3 months. And the follow-up ophtho exams and audiograms are at some interval of every 3 to 6 months. That's for patients just on oral therapy. And again, may be increased when they're on IV. We usually do our audiograms monthly for patients on IV therapy, but it's going to be individualized based on your patient and their comorbidities. The other thing I did want to point out, because Keren obviously pointed out a number of side effects. And if a patient hears this, they're going to be very apprehensive to starting any therapy. But there was a very nice study done by those at Tyler, Texas, looking at patients on 3 times a week therapy, particularly those with the nodular disease, 3 times a week therapy. And it showed the wonderful compliance that patients were able to have on intermittent therapy. And greater than 90% of those patients were able to tolerate the 3 times a week therapy without any change in their medication regimen. So I like to tell patients that, specifically the ones that we are putting on 3 times a week therapy. When you get to moving to daily therapy, you do see more of the side effect profile, and especially when you're adding the intravenous medications. And that's going to even be more apparent in one of our next seminars that we're going to do, talking about Mycobacterium abscessus and treatment in that group. But for 3 times a week therapy for nodular disease, I usually tell our patients that it is pretty well tolerated and that we're there for them to give us a call if any new symptoms start, so we can deal with things very early on. Okay, thank you. Thank you, Dr. Bakal, and thank you, NP Singer. We are going to let those know who are listening that this is Chest Pulse. I'm Dr. Addrizzo-Harris, professor of medicine at NYU Grossman School of Medicine and director of our NYU Bronchiectasis and NTM program. And joining me today to discuss initial treatment strategies for these patients, we have one more section on comorbidities coming up. Our Dr. Bakal, a pulmonary attending in New Jersey at Summit Health, and a senior nurse practitioner, Amy Springer, at NYU's Bronchiectasis and NTM program. Okay, so let's touch a little bit about comorbidities. Since we know these patients, the majority are over the age of 65, and they have a number of comorbidities that need to be evaluated, not only to improve their symptoms, but also if the comorbidities are evaluated and treated, often their underlying bronchiectasis disease may improve. So, Amy, let's start with GI comorbidities. What types of GI comorbidities do you find and evaluate for in these patients with underlying bronchiectasis?
So first off, it's important to have a multidisciplinary team approach in caring for patients with underlying bronchiectasis. Not only are patients referred to GI, but they're also referred to ENT and at times immunology as well. So for patients with GI comorbidities, especially for those who have lower lobe disease in particular, it's important to refer for a full GI workup and evaluation. Patients may undergo swallow evaluation, And if it's abnormal, they would receive swallow therapy exercises for abnormalities, as well as for the GI workup, they would undergo manometry, endoscopy with Bravo, and pH impedance testing to see if there's any silent reflux disease. As you mentioned earlier, perhaps if something is found on any of these exams, then there may be treatments available that would then be able to improve their underlying bronchiectasis. As mentioned earlier, there are patients who have additional comorbidities that require referrals to other providers. So it's important to refer to ENT, as we do want to exclude sinus disease, as it may be possible the sinus abnormalities are leading to progression of bronchiectasis on a CT chest scan and or patients having recurrent exacerbations. In addition, during our initial workup, we will test for immunoglobulin levels at our site. If there are any abnormalities, we will refer to immunology for further workup and evaluation. It may be found that some patients may qualify based on their results for IVIG infusions, and there has been studies that show that patients have positive clinical outcomes and reduction in bronchiectasis exacerbations requiring antibiotics once starting this IVIG. It is important that as providers, we do a review of symptoms to try and elicit these problems in these areas. But even with patients with no GERD symptoms, we know that a significant proportion of patients have asymptomatic reflux. So for those patients at higher risk with particular multilobar disease, lower lobe disease, or with recurrent exacerbations in a year, we will also definitely be on the lookout for asymptomatic reflux disease.
Absolutely. Very, very important. And as you're working up these other systems, sometimes that turns out to be the etiology of the underlying bronchiectasis. And again, you did refer, and I know we have a session on etiologies, but just to point out, if you find significant sinus disease, you may be dealing with an adult patient with primary ciliary dyskinesia. So then that would make you think of doing a further workup for that, et cetera. So I do think the multidisciplinary approach and the very comprehensive review of systems is extremely, extremely important in patients, particularly those with, more severe symptoms and more severe multilobar disease on CT. There are other very important areas in our 360-degree comprehensive care of these patients that we must pay attention to. And I would say that many of these are left to the bottom of the list because we are all in busy clinics and don't have time for everything. So that's why someone mentioned earlier, sometimes having multiple visits early on with these patients in order to tackle these separately, because sometimes it's overwhelming for a patient to go through 10 different areas that you want to work up or you want to assess. And patients I do think, have a fatigue response to too many areas of questioning at a one-time sitting. So we may say, let's get airway clearance started at the first sitting, see them back in 2 to 3 weeks, see how they're doing on that. Then we might talk about all of the different comorbidities and then have them come back a third time to talk about areas that need assessment within the nutrition spectrum and in the psychosocial spectrum, which those areas are, we know, extremely, extremely important. So, Dr. Bakal, how do you assess, let's start with nutrition in your patients, and what resources do you have to help you with that?
So you definitely want to assess these patients early in terms of their nutritional status. You want to identify any issues with appetite, any eating disorder. You want to see if there's been any weight loss, and also if they're underweight, and try to intervene early prior to them becoming malnourished. And you want to try to screen the patients at the first visit about regarding their nutrition. And just know that if they're going to end up starting treatment for MAC, this can make things worse. Some clinics have nutritionists on site. we tend to refer patients to nutritionists if they have a low BMI or they are malnourished. And one of the challenges with that is many nutritionists do deal more with overweight or obese patients. So they would need to be assessing them more for the opposite issue.
And as we mentioned earlier, we know psychosocial issues may, number one, be the reason for the weight loss. In some patients, it may not be their underlying bronchiectasis, but we also know that anxiety and depression is fairly common in this group of patients. So how do you address those issues, and what resources do you have to help patients with that?
Right. So the prevalence of anxiety and depression can be high in bronchiectasis patients. So you also want to identify if they have any anxiety or depression in your office visits. You can screen patients with just a simple screening test like the PHQ-2 test. And if they have an elevated score or they're expressing any sentiment of being anxious or depressed, you can then refer them for psychiatry or psychology. And just touching upon, we just talked about nutrition. If there is an eating disorder, again, contributing, you could refer to psych to help with management. Other resources as far as helping manage these symptoms besides psych, you can also refer patients to, or at least with psychiatry follow up, they can also start pulmonary rehab if they don't have an exercise routine. That can be helpful, improving some of the symptoms of anxiety and depression in this patient population and improving their quality of life. There are also multiple support groups available, which was touched upon already, but just to reiterate, there are support groups for patients that exist statewide, which can assist patients, and many of these groups are virtual, which is convenient for patients. Bronchiectasis and NTM 360 have an ambassador program that's helpful and allow patients to meet one-on-one with another patient with a disease, which could provide support to these patients. NTMIR is a website that directs patients to supportive online communities and local support communities. And there is a patient conference prior to ATS, which is 2 days long, can be in person or virtual, which also provides patients with support and education and other treatment options.
Yes, there are a lot of support groups across the country, as well as patient symposiums that are hybrid. The NTMIR site often lists a lot of them. And we at NYU have one every December that is virtual as well as in person. And so a lot of this actually is shared and stored on our program's website. So lots of resources out there for patients. We know there are obstacles in getting in to see psychologists and psychiatrists often, particularly with insurance coverage. So some of these other areas may be useful to get started with while you're dealing with those other obstacles. So at this point, I want to thank my guests, Dr. Bakal and Ms. Springer, for joining me in today's discussion. I hope that you have found it educational, and I hope that this impacts some of the care that we are able to give our patients with bronchiectasis and NTM lung disease. It was great speaking with both of you today. Thank you so much, and thank you for listening to Chest Pulse.